I'm Donna Zarconi, President and CEO of the Economic Club of Chicago. And I am honored to welcome Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases at the U.S. National Institutes of Health, as well as our fellow Economic Club member, Dr. Bridget Coughlin, President and CEO of the Shedd Aquarium. Thank you both for being with us today.
Thank you.
And I'd also like to welcome our guests that are joining from the Economic Clubs of New York and Washington, D.C. Our program will start with brief introductions followed by a moderated conversation between Dr. Fauci and Dr. Coughlin. And we will be accepting questions from the audience during this program. So please submit a question for consideration or upvote a question by using the Q&A tab at the bottom of your screen. This conversation is being recorded and we plan to post the content for general access on our YouTube channel at a later date. So now it's my pleasure to formally introduce our moderator and our guest speaker. Our moderator today, Dr. Bridget Coughlin, President and CEO of the Shedd Aquarium, is a nature lover and a scientist at heart. She holds a PhD in biochemistry and infectious diseases, and her commitment to learning and conservation extends well beyond the walls of the Shedd Aquarium. She spent 5 years with the National Academy of Sciences, where she served as managing editor of their signature publication, The Proceedings of the National Academy of Sciences. And it was there that she worked with Dr. Fauci, who served on her editorial review board. And their focus was on reporting critical research data, including a broad publication on their findings from the anthrax outbreak in 2001. And now to our honored special guest speaker. We're delighted to have you today. Dr. Anthony Fauci is a dedicated scientist and clinician, and he currently serves as director of the National Institute of Allergy and Infectious Diseases, where he oversees an extensive research portfolio devoted to preventing, diagnosing, and treating infectious diseases. Dr. Fauci has been a key advisor to 6 presidents and their administrations on global AIDS issues and on initiatives to bolster medical and public health preparedness against emerging infectious diseases. He has been instrumental in developing highly effective strategies for the therapy of patients living with HIV and AIDS, and thank you for your work on that. Dr. Fauci has also been awarded 45 honorary degrees and is the author, co-author, or editor of more than 1,300 scientific publications, including several major textbooks. So thank you, Dr. Fauci, for joining us. And now I'll turn it over to Dr. Coughlin.
Thank you, Donna. Dr. Fauci, on behalf of the Economic Club of Chicago, I want to welcome you at least virtually to Chicago. And we understand that your time is at a premium, but you're tireless. And it's clear from your staff that you are indeed tireless. Dedication to science and the public good and understanding in this pandemic means you have done a lot of these interviews. And I'm personally touched that you would agree to do ours today. As Donna said, I'm going to talk a little bit with you to hear more about the science of what is really the top news right now, which is vaccine development. And then Donna will tag in and talk more about the societal and global implications of this pandemic. So let's get right to it. You have used an interesting phrase to describe coronavirus. You have called it spectacularly efficient. What attributes does it have that gives that tag that you use for coronavirus?
Yeah. Well, I'm referring specifically, Bridget, to its ability to be easily transmitted from person to person. When you have a variety of viruses that the human species is confronted with, the respiratory viruses are generally reasonably well transmitted, but there's a broad range of how effective it is. In other words, what's the chance if you come into contact with a person who is infected with coronavirus or this novel coronavirus? What are the chances of your getting infected? I can compare that, for example, to the original SARS, which took place in 2002, which was also a potentially pandemic coronavirus that had jumped species similar to this coronavirus, which jumped from an animal reservoir to a human. But when it switches species, there's often a not very efficient way of going to human. This particular virus has an amazing capability. And we know that because look at what's happened. We first recognized at the end of December in China this brand new virus. And over a period of months, it has exploded throughout the world, causing a pandemic in virtually every country in the world, right here in the United States. I mean, obviously, you look at the numbers and they're very sobering.
Mm-hmm.
You know, we have now close to 150,000 deaths and several millions infections over a relatively short period of time. So when I say spectacularly efficient, I mean it, and not in a positive way because it's sobering and concerning, but it does among viruses spread very, very easily and very, very rapidly.
What do we know scientifically about that zoonotic jump and then human to human efficacy? And so it's able to jump and do human to human. What structurally on the virus do we think causes that human to human that's persisted despite not having a zoonotic intermediate?
Yeah, what happened is that and we've done structural biology on this very rapidly.
Mm-hmm.
The reason we call it a coronavirus is that corona standing for crown, and it has these spikes coming out of it. So when you look at it through the electron microscope, you see a round virus with these spikes coming out that look like the spikes on a crown. Hence, we call it coronavirus. But molecularly, there's a spike protein, an S protein there, that has what's called a receptor binding domain, which means if this is the spike, there's a part on the spike that binds very nicely to a cellular receptor in our body, in our upper airway, in our lungs, and in our GI tract. So when the virus goes from one person to another by the respiratory route, it binds to a receptor called the ACE2 receptor. And it is that mechanism and how efficiently and easily it binds to that particular receptor that determines how well it's going to transmit from one person to another.
Could that be the Achilles heel of the virus? So lots of companies are doing parallel paths for vaccine development. Some are using that S protein, hoping that it can, again, be the Achilles heel. Others looking at viral vectors, attenuated viruses. What of those methodologies do you put most stock in to develop that vaccine, to produce the vaccine at scale?
Well, Bridget, you used the word Achilles heel. So that spike protein, the way it's conformed, its conformation, is both its greatest asset in that it uses it to bind to the receptor. But you're right, it's its greatest Achilles heel, because the fact that you need that nice fit of binding with the receptor binding domain of the spike into the receptor of the cell, that when you develop a vaccine, which, as you know, we recently developed in the sense of being out there in a phase 3 trial, that you're looking for that vaccine to induce antibodies that specifically bind to that receptor binding domain of that spike to prevent it from binding to the receptor, which means that the ultimate target of a vaccine, the antibodies that a vaccine induces, is that spike protein. So, and in addition, drugs, which have antiviral effects, also can be directed against either structural components or metabolic components of the virus.
You referenced the vaccine, and it's been done through this tremendous, almost unprecedented public-private partnership. Two companies getting combined $2 billion from the federal government to advance this. Pfizer getting a contract for 100 million doses at $19.50 a dose. How does the federal government decide which companies to invest in and at what level to invest in the sort of unprecedented all out front against the virus with vaccine development?
Well, there are multiple elements of the federal government, mostly concentrated in the Department of Health and Human Services, but also to some extent in the Department of Defense, which we collaborate with very, very consistently. So what happens is that there are two elements. So you take the NIH, which is the institute that I direct, one of those institutes, infectious disease, that we have collaborations in a public-private partnership, which where we do some of the basic research that leads. For example, we developed the mRNA vaccine in collaboration with Moderna, and that's the vaccine that yesterday went into a phase 3 trial. We're utilizing our clinical trial sites throughout the country that we developed back in the early days of HIV to be clinical sites that you would do HIV clinical trials, either treatment, prevention, or vaccine. There's another element of government that relates to the money that you're talking about investing called the Biomedical Advanced Research and Development Authority, which actually takes away much of the risk of companies by investing hundreds of millions of dollars, if not $1 billion or more per company, to not only help them to develop the actual product, but also to make advanced purchases, which is what you're talking about just a moment ago, where you say, we'll put in X number of hundreds of millions of dollars to make the vaccine so that you don't need to worry about that, you tell the company. You're de-risking it because you want companies to get involved, but you don't want them to necessarily have to make this financial risk, because if they do, they may not be involved in developing the vaccine. And we do need a public-private partnership.
How do you determine, you've been consistently more optimistic than some of your peers about vaccine development. What's the basis of that optimism? Is it part of this parallel path of developing dose, whether you know it's effective or not? You know, this is an unprecedented speed of developing a vaccine, 12 to 18 months versus years and years. Why are you more optimistic than some of your international or your global peers?
Well, there are a lot of people who are also as cautiously optimistic as I am. There's always skepticism. I think the skepticism, I think for the audience to appreciate what we're talking about, there are two things going on. It's the optimism of getting a vaccine quickly, namely something that usually takes 7 years or so. You're truncating it into a relatively limited time frame, and you got to address, what does that mean vis-a-vis safety? What does that mean vis-a-vis the scientific integrity of the study? That's the first thing. Then the other issue is forgetting how long it takes. How optimistic or not are you that will actually work? So let's take those two things separately, because they really are separate. So the issue of doing it quickly is really related to things like the new technology. For example, when the virus was identified by the Chinese and the sequence was put on a public database, we within days, and when I say days, I mean 4 days, 3 or 4 days, took the sequence of the spike protein out and incorporated it into the vaccine platform, namely mRNA. And within days, we started to develop a vaccine. 62 days later, we were in a phase 1 trial. Less than 6 months later, we're in a phase 3 trial. That is unprecedented because of the technology and because of the financial investment, so that you don't wait until you finish one step before you go to the next. You invest in the next one. You prepare the sites. You buy and develop the vaccine itself while you're proving it works. So time frame, even though some people are not used to that because they're used to the classical time frame, the important thing to emphasize is that you're not sacrificing safety and you're not sacrificing scientific integrity.
How can we get that message out better? You know, there's always the cadre of the anti-vaxxers, right, and then there's now a new pool that think it's not safe because of that speed.
Right.
And you're describing, you know, a parallel path and doing step 2 even before step 1 is done, so that.
No, you're not doing step 2. You're preparing for step 2. You're making a financial investment. So we call that at risk, but the risk is purely financial. It isn't the risk of safety, and it isn't the risk of scientific integrity. So what you're doing is that you're saving time, but you're not cutting corners. That is clear. And we're very transparent about that. And the data is transparent as it comes out. But getting to the second part of your issue, which is equally as important, is why are we somewhat optimistic and cautiously optimistic that as we go into phase 3 trial, there's a reasonably good chance that the vaccine might work? Two issues. One, because the body makes a pretty good response against the coronavirus, and the overwhelming majority of people recover and respond very, very well, which means the body is inherently capable of making a good immune response against the virus. Number two, in the phase 1 study, relatively small numbers though it might be, those individuals in the phase 1 study mounted a response to the vaccine with a neutralizing antibody level that was quite robust. In fact, it was comparable to, or even better in some respects, than convalescent plasma of people recovering from it. And one of the tenets of vaccinology is that what you want to do, as you well know, you want to induce a response by your vaccine that's at least as good as, or hopefully even better than the response to natural infection. And that's what we've seen in these early studies. So you put those two things together, and it makes me feel that we should never, ever guarantee, because with vaccines, you can't guarantee anything, but to at least be somewhat cautiously optimistic that we're on the right path to getting a vaccine.
Let's fast forward to the day we do have that vaccine. How do we ensure the equitable distribution of it? You recently told Market Watch that you're going to put together a group of ethicists, clinicians, vaccinologists, community representatives to make prioritization of those first doses that are available. How does that work? Can you say more about equitable distribution?
Fine. So the Advisory Committee on Immunization Practices is the standard group that advises the CDC in just those types of things. Right now, the National Academy of Medicine is adding another complementary level, not to replace, but to complement, so that you really take a serious look involving all of the groups that you just mentioned, including people who understand public health, as well as ethicists and community representatives, to prioritize. Ultimately, we hope that we'll get vaccine that'll be available for everyone. But when a vaccine rolls out, you're not going to have hundreds of millions of doses on day one. You're going to have doses where you're going to have to prioritize. And right now, we're leaving it up to them. But if it follows the path that we generally do when you have scarce vaccine for a disease that's a serious disease, you generally do a few things. You get the emergency responders, the frontline healthcare providers who are putting themselves in harm's way to take care of people with coronavirus disease. Next, you take the vulnerable individuals who are more likely to have a serious outcome. The elderly, those with underlying conditions, and we know what they are because we have a lot of experience now over the last 6 months. Those with high blood pressure, heart disease, obesity, diabetes, chronic lung disease, kidney disease, those are the people who likely would have a poor outcome. So I don't want to second guess what the prioritization is going to be, but I think it'll be something like what I'm telling you about right now.
And then once we get past essential healthcare workers, those that have a predisposition or a condition for vulnerability, are there other layers though? What about child care workers or grocery store employees, farmers, meat packing plants? Beyond the medical cut, then how do we determine the next cut? Or by then will the doses be sufficient?
Hopefully the doses will be sufficient, but what you mentioned is interesting. Also in the group of high priorities are those whose function is essential for the adequate and smooth functioning of society, like police officers, people who have food chain suppliers, so that you don't want to cut off the supply of food to the community. So it's people who would have essential functions.
If we could take a step back, I was buoyed and pleased to hear that the scientific enterprise of sharing data is still functioning, that the scientists who had the sequence posted it available for all. Can you give you're still free to talk to all scientists everywhere. There's ample sharing and transparency. Is that still working? Is the Public Library of Science, not itself the journal, but the whole enterprise, fully functioning at a global collaboration level?
Oh, absolutely. I mean, we are all in this together. The Chinese were a little bit slow in the beginning of letting us know exactly what they knew about the ability of the virus to transmit. You recall early on, they were saying it really jumped species from an animal to a human, but it wasn't particularly efficient in going from human to human. And that is not the case. There was likely spread of virus in China for a few weeks at least before we figured out that it was transmissible from human to human. But right now, where we are today, there's a lot of interaction, discussion, transparency. For example, I'm on a call at least once a week that is sponsored by the WHO, where the health authorities from essentially every country in the world that has any degree of COVID-19 involvement, and we exchange information. We talk about what's going on in this country. What are you doing? What are the successes? What are the failures? How can we do better? That's what's going on. So there really is a lot of communication, transparency, and sharing of information.
That's great to hear. We're saying sequence as if it's static. Is it a singular strain? Is there any antigenic shuffling or drift?
Well, coronavirus is an RNA virus. And by definition, almost, RNA viruses tend to mutate. But the mutations are not always associated with a functional difference or a functional change. So yes, we can see mutations as the virus that was around in January, February, March is a little bit different than the virus that's here now in June, July, and as we get into the middle of the summer. But thus far, the only thing that we've seen is that there has been a mutation on one of the amino acids, which indicates that the binding to the receptor might be more efficient, which means it could be a bit more transmissible. But that hasn't been proven in vivo in the wild. Theoretically, it's the case from what we see in vitro. But a good news about that is that that mutation is not in an area where we feel it would have any impact on the response to or efficacy of a vaccine. So even though it's changed a little, it's not going to interfere with the success or failure of vaccine development.
So the S protein itself and the immune response, the spike protein, it's the same. It's just the efficacy of binding maybe shifting.
Exactly.
You mentioned your colleagues in this phone call. You have a reputation for being an incredible team player, and you have said it's almost impossible to do anything without a team, leading a team or being part of a team. Tell us a little bit. We see you at the global stage. Who's on your team internally? Who do you seek counsel from there at NIAID and NIH?
Well, I'm, as you know, because we've done this together back in the day, Bridget, I'm a scientist. I'm a public health person. I'm a clinician. I'm a physician. That's my identity. So when my responsibility, in addition to being on the coronavirus task force, where I give opinion based on my analysis of either both scientific as well as public health data, but my inner core here at the NIH is my team. I mean, people from the Vaccine Research Center, the people who developed the mRNA vaccine, John Mascola, Bonnie Graham, and his group, names that you're very familiar with, Julie Ledgerwood, my own team, Cliff Lane, who has been with me for years and years, my clinical director, and a person who's as good at analyzing clinical trial data as I think anybody in the world is. I talk to him 5 times a day. So and Francis Collins, who's the director of NIH. Francis is, one of the world premier molecular biologists and geneticists. So I get a lot of really good input and discussion with a really high quality team. And that's what I mean when I say, if you're part of a team like that, it really enhances your effectiveness.
You mentioned Dr. Collins, Francis Collins. So you took your post in 1984 and you hit a career plateau. Why have you never taken the top job at NIH?
Well, when I was offered the job as NIH director, I made a decision that I think was really the right decision for me, in that I wanted to stay close enough to the actual conduct and implementation of the science. I wanted to keep my own lab, which I still do have. I wanted to continue to see patients, which I still do. I think if I assumed the responsibility as the director of all of the institutes at NIH, as opposed to staying very close to my core competency, which is in immunology and infectious diseases, I would be better off. And actually, I think that was really a good choice because A, I've been able to do my job in that capacity. And we've had some terrific NIH directors, including our current NIH director, who is Francis Collins, and before him, a number of them, Harold Varmus, Elias Zerhouni, et cetera, et cetera. We've had a lot of good ones.
Mm-hmm. How do you keep your team motivated? I mean, there's not a leader on this call who hasn't at sometimes felt exhausted or had to buoy their team, other than watching baseball, or I don't imagine that you're sitting around doing puzzles and tie-dye and looking for sourdough recipes or watching penguins on social media. How do you fortify yourself, and how have you supported your team? Because as you've mentioned many times, we have a long way to climb out of this. This is a marathon, not a sprint.
I don't know whether it's a good thing or a bad thing, Bridget, but I'm an unapologetic workaholic.
I know.
That's what I do. I get charged. My charging up is the challenge that we're facing. I mean, when you get up in the morning and I get the numbers and you look at the numbers, 1,000 deaths yesterday, almost 150,000 deaths total, a few million infections in the United States, 70,000, 60,000 new infections each day. That's my motivating force. I don't need any recharging of batteries. I just look at those numbers and say, we have a big job ahead of us.
Lots of people are writing books. And even if you just said the word book, you would be a bestseller before you got the K out of your mouth. What would you write about? What's your book going to be about?
Well, it would be my experience over not only now, but many years of addressing emerging infectious diseases. And as you know, I've had the privilege of advising 6 administrations, 6 presidents. So all the way back from Ronald Reagan through George H.W. Bush and Clinton and George W. Bush and Obama, and now President Trump. So I think that's something people would be interested in when I get around to
Reagan,
it.
you really moved public discourse on HIV/AIDS. You had a president who really wouldn't even utter the words or recognize it as a national emergency, to the second term when Ronald Reagan was fully supportive of your work and of the narrative and the science behind it.
It just goes to show if you work on them, you could change them.
You have outlasted many recalcitrant people, and I'll leave it at that. Right. Let's go back to the global platform stage for a minute here. You mentioned the zoonotic jump, and some people, including Inger Anderson, who's the executive director at the United Nations for Environmental Program. This is sort of the intersectionality between public health and conservation as ecosystems are disrupted, as the human population becomes more dense and more concentrated. Is this, I hate the phrase new normal, but is this particular pandemic a signal of our future, that this will happen with more rapidity and no longer be a once every 100-year event?
Yeah, I think there's something to that, Bridget. If you look at the new infections that have gone into mankind, brand new things that historically they've never been exposed to, about 70% of those are zoonotic, namely infections that jump from an animal to a human and then adapt itself successfully to humans. There are pathogens that jump and hit the human and it's a dead end. It goes nowhere. It's sort of like 1 or 2 off and then you're done. But then every once in a while you get something like HIV/AIDS, which jump from a chimpanzee to a human. The influenzas, evolutionarily are fundamentally viruses of wild birds that over the centuries and centuries have adapted themselves to humans. Ebola, same thing, jump from an animal species to a human. And what we're dealing with right now with the novel coronavirus does that. And you're right. When you encroach upon the environment in which animals that don't have much contact with human, or when you really crowd the animal-human interface, we see that a lot in China and the Far East, where you have pigs and ducks and chickens and humans very, very close together. And you have influenza, which is a virus that can exist in wild birds, in pigs, and in humans. The chance of those viral genes mixing up, reassorting, mutating, you give it a really good chance to spill over into humans.
Yeah, sort of a cocktail of environmental conditions that's a perfect recipe for it. The I think some of our readers are, hi Donna, are curious about what the rest of your day holds. You know, we got the green light that we were going to have, definitely have your time, and again, we're grateful for it. What does the next 24 hours look like for you, Dr. Fauci?
Well, it's a typical day. So I'm here at the NIH right now, and I'm doing work that's National Institute of Allergy and Infectious Diseases, very heavily skewed towards the coronavirus pandemic, because that's occupying virtually everyone's attention and energy. But we also have responsibility for HIV/AIDS, that's still a global problem, malaria, tuberculosis. So I spend the first half of the day here. So as we get into midday, I go down to the White House. So I'll be spending most of the day as a second part. Well, you know, there are more than two parts of the day. Even though there's morning and afternoon, there's also night, really late, and morning, really early. So I will go down to the White House this afternoon and participate in the coronavirus task force. Then I will have another responsibilities down there with my colleagues at the White House. And then this evening, I'll come back here and continue the work here. You know, I have a lot of meetings, a lot of responsibilities of things that are going to be going on. So it'll go into late at night. I'll get home reasonably late. I'll probably go for a quick walk, power walk, or run with my wife, and then sit down in front of my computer. And one of the things that's unavoidable is that I get now, because of the visibility of this, I get easily over 1,000 emails a day, easily. My staff screens much of them, but then I'm left with at least a couple of hundred that I have to look at. That sometimes goes into the wee hours of the morning. Sometimes I can cut off at 11 o'clock, sometimes not. But it goes from the early morning to the night. Yeah.
Thank you for pointing out too that while the pandemic is first and foremost in our mind and obviously consuming lots of our time and is the true urgent work of the day, that there are lots of complexities that you're working on in addition to that. And so thank you for calling out the HIV/AIDS and tuberculosis and the whole suite of other things. So Donna, I'm happy to see you hop in, and thank you, Dr. Fauci. Looking
So
forward
I wanted to just jump in here because we're getting a lot of questions, but I did have some questions about a little bit more about the scientific process. So you two must have had some interesting discussions back in 2001 when you were deciding whether to publish the recipe for anthrax and the potential bioterrorism implications of that. When you did decide to go ahead and publish it in the Proceedings of the National Academy of Sciences. So how did that process go when you have something that's an ethical issue, a discussion like that, and how do you go through that debate and thought process? Bridget, Dr.
Sure.
Fauci.
This was a time too when lots of scientific journals were behind subscription firewalls. So open access publishing, Public Library of Science. So it's not only should you publish it, but then should you make it more widely available so that this sort of intellectual collaboration that Dr. Fauci described can happen, regardless of high fees for readership. It's about science in the public interest. So there's two questions. Should you publish it? Because it could be, as I referenced earlier, the recipe for the bad guys used for nefarious reasons, or are you making it widely available so that it's in the public interest and that all scientists and the National Academy of Science took a real lead on convening individuals like Dr. Fauci to come up with the most ethical approach to that. And ultimately, guidelines were published, and there's ways to track that. And the CDC keeps a list of bioterrorism agents. And ultimately, I think it's the best thing for science and public health.
So Dr. Fauci, how do you go through that decision process?
Well, I mean, I think it's exactly as Bridget said. You have to balance making something, information publicly available so that you can get people who are working on it to protect society. There's always a risk when you make sensitive information available that someone will use it nefariously. So you get people who are unbiased, who don't have any skin in the game for a particular microbe or a particular product, and you run it by them. You don't make a decision in a vacuum. You really want to get people who have experience in this, who make a better judgment as to what you want to make public so that people can work on it and protect us versus make it public to be used in a nefarious way.
So let me pivot that just a little bit more to one more question around the scientific decision-making process, because clearly there's been so much information, and this has been a period in these last 6 months of very intense learning. So what process, Dr. Fauci, do you use to make a decision when there's imperfect or just preliminary, incomplete data? So how do you make a decision with that? And then how do you course correct as more data is received, including issuing revised guidance?
Well, I mean, that's a very good point. This is critical when you're dealing with an evolving process like a brand new pandemic. And that's exactly what happened in the early weeks and months as we started to learn more and more. When you're in an arena of science and public health, you go by the data that you have. Often, if you're dealing with an evolving situation, almost by definition, your data are incomplete. But just because your data is incomplete does not mean that you're not going to have to make recommendations and guidelines, because the public, both the general public and the scientific public, need guidelines and policy about how to proceed. So you may make a guideline in January or February based on the information that you have. And then when you get into March, April, and May, you get information that's different, and you get more information, and that spurs you to change either a decision or a guideline or a policy. That is the nature of science. Science is not static. Science is an iterative process that is inherently self-corrective as well as self-confirmatory. And I think that's what people need to understand, that as long as you, in good faith, make a decision on the information that you have at the time, then that decision is correct because it is based on scientific truth at the time. As you go on, you should be humble enough and flexible enough to make modifications as the data shows that there are other things there that you may not have considered. I mean, typical example is we didn't realize early on that asymptomatic infection occurred to the extent that it occurred. Like maybe 20 to 45% of all the infections are without symptoms. And an asymptomatic person with coronavirus infection could easily infect another person, even though the person has no idea that they're infected. That played a major role in the guidelines of physical separation, wearing masks essentially all the time, once we found out that information, as opposed to very early on when we didn't know that at the time.
We didn't always know, to your wonderful phrase, that it was spectacularly efficient.
Right.
But it's a very smart virus to be a latent virus so that you walk around and transmit it, and therefore it can infect bigger.
So we have upvoting going on in our questions here, Dr. Fauci, so probably won't come as a surprise to you, but there is a lot of concerns about the rising level, appears to be the rising level of infections in younger children. And Illinois and Chicago have issued specific guidelines for reopening schools this fall, including a hybrid model where 2 days in with 2-1-2 and then independent learning with smaller cohort groups. But once we go back and open the schools, what leading health indicators must we monitor to know if it's working? And can Chicago really open up schools given some of the rising levels that we're seeing on a national basis and the amount of transfer of people between cities and states?
Yeah, I mean, I think there are a couple of general principles that you have to state before you get into the granular aspects of what particular school can or should open or not. So the fundamental principle is that we should make as a default that we should try as best as we possibly can to keep the schools open or to open the schools when they're ready to open as we enter into the fall term. Having said that, there's a however, and the however means we've got to be very sensitive to and attentive to the safety and the health and the welfare of the children, of the teachers, and of the families involved. The reason you want to try to open the schools is that we know that there are unintended downstream ripple effect negative consequences of keeping children out of school, both psychological effects on the children, as well as on working parents who need to modify what they do to stay home to take care of the kids. However, you don't want to sacrifice safety. So therefore, what has happened is that we live in a very large country that is very heterogeneous with regard to the level of virus in any particular state, city, or even county. So you want to open the schools, but you've got to be careful. If you have a district or a county in which there's almost no or very little active viral transmission, then with impunity, you could probably open the schools without any problem. If you happen to be in an area where there's a slight to modest amount of infection activity, you might want to do some of the things that you've been discussing, Donna, things like a hybrid model or physical separation, wearing masks, alternating schedules. If you're in a region, an area, a county where there is a very, very wide outbreak of virus, you might want to think twice before you even open the school. So I think it needs to be something on a county by county, city by city, state by state basis. Look at the data, look at the degree of activity of virus, and make your decision there with the ultimate default of trying as best as you can to keep the kids in school, so long as you pay great attention to their safety, their health, and their welfare of themselves and of their parents and teachers.
And just a follow-up, is there indication scientifically that the younger children are getting more susceptible to this?
Well, you know, the more and more you look, there was a recent study that came out that said that children 10 years old to 19 transmit the infection as readily as adults transmit the infection. There's still data that we need to accumulate about the susceptibility and the transmissibility among younger children. There are some statements about that, but we need more data. We don't have definitive data. And in fact, what we're doing at the NIH is that we started a study on May 1st, and we should get enough data by December of this year in 6,000 people in 2,000 families. And by people, I mean children, to determine what is the incidence and prevalence of infection at different age groups, and do they or do they not transmit it to their parents, and or do parents' infection transmit it to the children? Mm-hmm. That's a study, as I mentioned, that we started just on May 1st. Hopefully we'll get enough data to make a statement by the end of the year.
So more to come, like this we talked about earlier. As we learn more, we'll be able to adapt more. Another question that's coming up here is more directed towards you, but it's how frustrating do you find it as a public health leader that Americans are choosing individual liberty over societal responsibility?
I mean, obviously, I think you would know what the answer to that is. That's very troubling to me as a physician, scientist, and a public health official. I think what people don't understand, and in some respects, it's an innocent misunderstanding. I don't think there's anything nefarious in any of this, but people maybe do not appreciate something. You know, as Bridget had mentioned, I have experience in dealing with viruses that go back 35, 40 years with HIV, Ebola, pandemic flu, anthrax outbreak, chikungunya, Zika. So I've seen a lot of viruses. But one thing about this virus that's so unique is the broad range of involvement of seriousness or not. So you can get 30 to 40% of the people who have asymptomatic infection, doesn't bother them at all. Some people get mildly ill, symptoms that don't bother them that much. They stay home for a few days. Some people are in bed at home for weeks at a time and may even have after effects. Others get hospitalized. Some in the hospital need intensive care. Some require ventilators and some die. So it's so unusual to have the same virus that in so many people does nothing and in other people kills them. So when you see people who don't want to adhere to the guidelines of masking, physical distance, it's because particularly young people, they look around and they see their younger colleagues who might get infected, and the chances are they're not going to have a serious outcome. What they're missing are two things. One, some young people do get seriously ill. So don't assume that you're invulnerable, because we've seen plenty of people in their 30s and 40s and even 20s who can get seriously ill, even though statistically it isn't as much as older people. Point number two, what people don't realize, and I think mostly young people, they think if I get infected and I don't have any symptoms, it doesn't bother or hurt anybody else. So why are you telling me what to do? Why are you telling me to wear a mask and to be physically distant? You're an authority. I don't want to listen to you. What they tend to fail to realize is that by your getting infected, even if you have no symptoms, you are propagating the pandemic. You are part of the problem, because what likely will happen is that you will inadvertently and innocently infect someone else. That person might then infect someone else, who then infects someone who really is vulnerable, an elderly person, someone's mother or wife who is under chemotherapy for breast cancer, an immunodeficient child, someone who has an underlying disease like diabetes, and then another person has gotten harmed because you have innocently and inadvertently didn't care about your getting infected. So you've got to instill in people both the personal responsibility, because you don't want to hurt yourself, obviously, but also a societal responsibility that you don't want to be part of the problem of propagating an outbreak.
So wouldn't that call for then a national mandate on mask wearing? There's questions coming in, like if we all just wore masks for 3 or 4 weeks, couldn't we just significantly change the outcome here?
That caller is correct. If we did 4 or 5 fundamental principle things, wear a mask at all times, particularly when you're outside of your home where you don't know the kind of interaction you might have. Stay physically distant, 6 feet at least. Avoid crowds. In your region, if you have any authority, close the bars or stay away from bars. When people mingle close together, that's where the real spreading ground. And practice personal hygiene of washing your hands, soap and water, or alcohol type wipes. If you do those 5 things, you could have a major impact on turning things around. That's not very difficult to do.
So why wouldn't it become a mandate or a law?
Yeah, well, one of the
more teeth into it.
Yeah, we're appealing to people's understanding. I'm strongly recommending the way I'm doing with you right now. And the reason is that when you do mandates, then you have to enforce it. And when you're enforcing mandates, that gets very complicated. What are you going to do? Get the police to arrest someone? So, I mean, it would be nice in a perfect world to mandate something so long as everybody essentially abided by the mandate. If you strongly recommend it to people and appeal to their sense of public awareness and public service, hopefully you can get as far as if you mandated it.
So we have almost 800 people watching right now, and close to 50 questions being submitted. But one question that is coming up is there an unasked question that you wish we would ask? Because you've done a lot of interviews. Is there some message that you want to make sure we hear?
Well, yeah, and I think that is because when you're dealing, we've now been doing this for almost 6 months. If you look at, the beginning, it was not quite sure what was going on. Then in earnest, we really got hit. So it's about 5 or 6 months. One can get worn down and say to yourself, oh my goodness, I'm so discouraged. Will this ever end? People who are locked in, people who wear masks, who do the right things, it can be wearing on you psychologically and otherwise. The message is this will end. We will get over this, and we will ultimately get back to normal, both by practicing public health measures and by the science that will give us a vaccine and that will give us adequate therapy. So don't get discouraged. Don't give up. Hang in there. We will get through it. And you can be part of the process of helping us get through it by merely doing the public health measures that we've been talking about.
So I just wanted to come back to another question that came up, because I agree with you. I think that we need hope, and there's reason for hope. You're a sports fanatic, and obviously, congrats on throwing out that opening pitch at the Washington Nationals. I know there's a number of our members who love sports and would love to see the players back on the field. How do we keep them safe?
Well, it depends on the sport. As you know, there have been different protocols. I've had the opportunity to discuss with some of the owners and league officials and player representatives about protocols to keep the players safe. If you're dealing with a sport in which many sports now realize that there are not going to be spectators. When I threw out the opening pitch at the first game between the New York Yankees and the Washington Nationals, Nats Stadium was empty. It was televised, but therefore the safety of spectators were okay. If you don't have them there, they're not crowding together. So you really got to focus on the safety of the players. You could create a bubble by testing them all once, frequently, maybe even every other day, or surveillance. Keep them with their family in a semi-sequestered way, in a bubble, as it were, and to see if, in fact, you can prevent them from getting infected. I think that will work, but you don't know. We had a somewhat sobering experience just yesterday where, in baseball, you can test the players every day if you want to do that and to keep them safe. But, the Miami Marlins had a dozen of their players got infected. Mm-hmm. So then that makes you question, gee, can we really protect the players as much as we want? I think we can. I think the season still can go on the way the protocols have been written. But you always got to remember, primarily, you've got to be careful and be sensitive to the safety of the players. And secondarily, because with their families, the safety of their families, as well as the other personnel are involved.
Okay, we're coming up to our time, and this has just flown by. So we would love to have you back at a future date if we could arrange it. It's been a fascinating interview. Bridget, any closing comments for you? What gives you hope?
People like Dr. Fauci in the chair that he is in, and the fact that he's keeping his eye on paying it forward, cultivating the team writ large. And so science will solve this, and humans are part of that scientific endeavor. So thank you for being a good humanist.
Thank you. And then Dr. Fauci, closing comments for you before I wrap up.
Well, I think the closing comments was the last question you asked me. We all need to hang in there. We're all in it together. It's going to end. We're going to get through it. but we have a job to do to get through it. It's our responsibility. And thank you very much for having me join you today. It's a pleasure.
Yeah, it's been fascinating. So I'm going to close by saying thank you to each of you for this very insightful and informative discussion. We really appreciate you taking the time to be with us today and answering questions from our business community, our membership. And to our members, we're always interested in your feedback, and we will be sending a survey after this program. And to all, please stay safe and remember, as Dr. Fauci has advised us, that we are all in this together and we all need to be part of the solution. So please wear your masks, practice social distancing, careful hand washing, and please avoid interacting in large groups. Listen to our good doctor and our great scientists, and we'll get through this. So thank you and take care.
Thank you.